in the rest of the world to commemorate World AIDS Day, that is always commemorated on 1st December 2024. We are talking about 42 years since the first case of AIDS was diagnosed in Uganda, that is in 1982, and since then Uganda AIDS Commission was established 10 years later to coordinate and multiple sector and stakeholder national HIV response. We also have the Ministry of Health that is responsible for all the HIV prevalence and all the treatment and the care, and we're also going to be talking about those who are advocating for HIV and AIDS in this country to make sure that the people of Uganda really have or live good lives. A very big privilege and honor to have in the studios of UBC Dr. Arthur Ahimsibwe is the National Teal for Adult HIV Care and Treatment, coming from the Ministry of Health, Uganda, and is so much in charge of AIDS control program. Welcome, Dr. Arthur, to this edition.
Thank you so much, moderator. It's a privilege basically to be here, and you would allow me greet the listeners of UBC, the great mighty radio. Like you mentioned, I'm Dr. Arthur Ahimsibwe. I lead the adult care and treatment unit at the Ministry of Health, but also mention that here in representing the who is the Assistant Commissioner, Dr. Mutumba Robert. So it's good and in honor to say that may the sisters' soul rest in eternal peace.
Amen. Interesting. You've heard from Dr. Ahimsibwe. You're going to be joined by Dr. Daniel Byamukama, who is the head of HIV prevention coming from Uganda AIDS Commission, and we're also going to have Flavia Chomkama, who is the executive director of AGA, or Action Group for Human Rights Action, coming from all sides and all sectors, covering HIV prevention programs and treatment, especially in Uganda. You well know we have a theme, Uganda. We are talking about ending AIDS by 2030, and we are looking at keeping communities at the center, but also looking at the international theme, which is also very important for us to take note, is that we have to take the rights path, and my health, my rights. This theme really emphasizes how important our human rights are to reaching the 2030 AIDS reduction target, and we had said that we can end AIDS by 2030. I don't know how that is possible, but with the guests that I have in the studios, I believe that we are going to be so much informed and educated. I would Ahimsibwe, perhaps you could tell us what the ministry is about and the program that we lead, but also telling us how far we have gone in the fight against HIV and AIDS in this country. Welcome, Dr. Arthur.
Yeah, thank you so much, moderator, as usual, and thank you so much indeed, colleagues and generally Ugandans that are listening to the mighty radio UBC, but also to mention that we are yet to celebrate the World AIDS Day that is starting tomorrow in Buyende district, and our chief champion in the fight against HIV as a disease in Uganda, that is His Excellency General Kaguta Yoweri Museveni, is expected to be our guest of honor. So the fight HIV in Uganda has been on for the last 4 decades, that is around 40 years, since 1980. The one today, the 2024, with a sense of reflection, celebration, and renewal, part of the things that we basically front. Per se, it is a day that reminds us of our collective responsibilities as Ugandan citizens in terms of addressing HIV epidemic, but also in terms of honoring the lives lost to AIDS and stand in solidarity with those people that are living and affected by HIV. But also, Amon and colleagues, it is also a day for us to reaffirm our commitments in our various capacities towards ending HIV as, AIDS as a public health threat by 2030. And this is clearly captured in the theme for this year's World AIDS Day theme, which states that we aim at accelerating the interventions to end AIDS by 2030. So at this particular moment in time, moderator and the dear listeners, it is, I think, important for me to give you a few shots of the statistics in terms of how far we have gone since 40 years back. Now, in Uganda, when you talk about the AIDS, I think as a program, we qualify to be termed as a mature country in terms of fighting the epidemic. We are a mature program in the sense that when you talk about the incidence, what we call the new infections, we have tremendously and significantly reduced new infections from previously what it used to be around 2010, just a decade back, we were talking about 100,000 new infections every year. Today, as I stand here in the studios talking to Ugandans, we are talking about 38,000 new infections. That is a tremendous gain, more than 60% reduction in terms of new infections, scientifically what we call the incidence. But also when you talk about the deaths, AIDS-related deaths, just a decade back, we were talking about 60,000 deaths. Today, we are talking about less than 20,000 deaths that are related to HIV. So you can see that when I say that we have moved tremendous journey, but a journey that is worth celebrating in terms of success, I cannot be caught out of context. And this is not something that we at the Ministry of Health have done alone. Like you clearly mentioned, there are quite a number of stakeholders in terms of look at the Uganda AIDS Commission, look at different ministries, different departments, different agencies that have mainstreamed HIV within their day-to-day activities, but also look at different personalities, quite a number of stakeholders that have supported in this fight against HIV. Initially, I talked about the president. He has been the champion. Quite a number of stakeholders that have supported in this fight. But also to mention that even when we have led this fight, and even in the region, we are seen as a model country in terms of fighting the HIV as an epidemic, I think it is also important for us to note that there are quite a number of challenges that we have met. I know that as we go on, I will be mentioning a number of challenges. So, Amon and the listeners, you will bear me witnesses that as a country, we have had what we call primary prevention. Now, primary prevention is something that people are getting complacent about. Primary prevention, if you recall, we used to have abstinence, we used to have what we call being faithful, but also optimal and consistent use of condoms.
The ABC.
Yes, the ABC model or the ABC approach, or you can call it the ABC strategy. This is something that people are tending to start to forget, I think because of complacent, because of the availability of drugs. And I want to encourage members, the community members, and everybody in your various capacities, religious leaders, political leaders, to again rejuvenate this kind of message. It is something that supported us in terms of reducing the infection, in terms of ensuring that we are protecting ourselves against this deadly disease. But also to say, Amon, that on top of the prevention, what we call the primary prevention strategies, the Ministry of Health, working together with various stakeholders, introduced what we call combination prevention. Now, with combination prevention, you're looking at the primary strategies that I have mentioned, but you are combining them with also other strategies. And some of those strategies that we are talking about, first and foremost, is to prioritize optimization of HIV testing, but also what we call prevention of mother-to-child transmission. Now, when you talk about prevention of mother-to-child transmission, it is something that is critical, and it is something that we need to pay a lot of attention. I think as we go on, we shall expound on what it is. But also to say what we call safe male circumcision. We shall also expound on it, but it is one of the combination prevention strategies that does not need to be left behind. What about when we talk about PrEP? Most of the people know it as PrEP programming, which has expanded from the few facilities that it used to be in to the many facilities. Now, when we talk about PrEP, it is what we call prevention even before that, before the PrEP, we have what we call the adolescent girls and young women, programming. That is something which is very critical. I am just mentioning the top cover. I know that as we go on, we shall be able to expound on this. So the program that I had talked about, what we call pre-exposure prophylaxis. This is something that we need to talk about, but in a manner that will not mislead society. I know that currently we have social media, which is regulated, but probably not very well regulated, because everybody now seems to be a qualified journalist in courts. So the PrEP, the pre-exposure prophylaxis, is something that is good for us as a prevention approach, as a prevention strategy, with the use of drugs, which are basically ARVs, that support us in preventing us from getting or acquiring the disease, especially those people that are at very, very high risk. But this is a term that I always want to use with caution. I always want to be given enough time to really explain, so that people don't think that because we have PrEP, then you can easily just go and languish around, play whatever you want to play, thinking that because drugs are there. It is not something that we need to pick in that direction. But also quite a number of biomedical interventions that we have brought in place, the school-based interventions that are in place in terms of sexuality education, life skills, menstrual hygiene for girls, our girl children, all those aspects are aspects that we have brought in place in order to support us, reduce the infection, but also reduce mortality.
Interesting.
Yes. So basically speaking, in a nutshell, Amon, that is nearly a summary of what we have in place as of now. But we continue to call upon everybody in your various capacities, religious leaders, political leaders. You have done very, very great work. But you realize that because of complacency, because of having drugs now, we are not as robust as how we used to be. The messages are not going the way how they used to be initially. So there is a need for us to rejuvenate our energy, refocus more, so that we don't lose the gains that we have had in the previous years, but also we aim at ending HIV, AIDS as a public health threat by 2030.
Interesting. Thank you so very much, Dr. Arthur. We are going to look into details of how possible that is to end HIV/AIDS by, is it AIDS or HIV, by 2030. Okay, we are privileged to be joined by Dr. Daniel Byamukama, is the head of HIV prevention at Uganda AIDS Commission. As we started our broadcast and this program, said that we're talking about 42 years since the first case of AIDS was diagnosed in Uganda. That was in 1982. Just 10 years later, we see the establishment of Uganda AIDS Commission, and we're talking about now 30 plus years. Would love to know how they have been at the forefront, especially in the fight against HIV, but most importantly, now that you come from the prevention department, we're going to look at how this has been put the end, but also looking at 2030, if it is very possible to end it, as Dr. Arthur and so many have been saying. You're welcome, Dr. Daniel.
Thank you. Thank you for hosting me.
AIDS Commission, the mandate, and how far have you gone in fulfilling that very noble mandate, but especially when it comes to the HIV/AIDS fight?
Thank you. So the Uganda AIDS Commission was constituted in 1992 by an act of parliament, by law, and put under the office of the president. The mandate of the commission is coordinate and provide the overall leadership of the HIV response. When we started this response around 1986, it was started mainly in the health sector. It was mainly led by hospitals and doctors and nurses. But the government that AIDS was a different kind of disease. HIV was a different kind of disease that required active engagement and participation of other sectors, including religious leaders, including cultural leaders, including political leaders, including educationists, including of national farming to pray, including people living with HIV themselves. So they formed the AIDS Commission to help coordinate all these sectors, to make sure everybody is talking to the same message, to the same goal, that the message of the is not contradicting the program of the health workers. We are all, our efforts are guided to focus on delivering the same results, so that we work together, everybody lifts on their part. We are working in a music show. So that is the work of the AIDS Commission, to develop overall strategy, remind stakeholders what part they are going to play in that strategy, and how, and to talk, to say, education, you are letting us down. The religious leaders, you are letting us down. And as we have a conversation today, I will mention some of the sectors and stakeholders who are letting the response down. Who have, my colleague Dr. Arthur here said we have gone into a mode. We have become complacent, but not all of them. Some of the health workers are working so hard. Some of civil society organizations are working hard, but even those are not hard. If the media sector, for example, is not busy doing their part, and the part to be done, to be played by the media sector is significant. But if they are not praying, even up to 50%, if they are praying around 30%, that really weakens the efforts of others. The part to be prayed by the religious sector is so important. The backbone of our HIV prevention, for example, is abstinence, being faithful, and condom use. Those are not really their behavior. We need to educate people about upholding those behaviors. And we see leaders like religious leaders there being very key. But are they performing at our expected rate? Could they be the compassionate stakeholder in this response? So as we discuss, we shall be making appeals to various stakeholders, because see us to 2030. We cannot afford to default on our goal of ending AIDS as a public health threat by 2030. When the president launched this campaign to end AIDS as a public health threat by 2030, several countries in the world also launched a similar campaign. At the time the president launched the campaign to end AIDS as a public health threat in Uganda, we were the leaders in the response. I remember we had set targets, global targets for the year 2020. Uganda were one of the first countries to attain those targets. We were still the leaders. We set other global targets for the year 2025 in our journey to 2020 to 2030. Now, what I see is that other countries, most of these countries, learned their way of how to respond to the HIV epidemic from here in Uganda. They came and learned from here. They borrowed our frameworks and guidelines and the protocols, but they are beating us. Some of them have attained the 2025 global targets. In 2023, Uganda, we have not yet attained. So which shows that our leadership in the HIV response is not as it should be, and which qualifies Dr. Arthur's submission that there is obvious complacency. There is some complacency. With only 6 years to go, we risk failing to hit the targets. So many other countries will hit the target of ending AIDS in their countries. We risk missing that target. But most important, we risk losing our gains. When you're at battle and then you start becoming lazy and sleep, the enemy overruns you. The HIV epidemic, our response to the HIV epidemic usually compared to war. War. When you are at war, your enemy is always attacking you and changing tactics. When you see the AIDS epidemic, it's always changing tactics. Today we are saying the epidemic is focused in couples. Next year we are saying the epidemic is focused in young girls. This year we are saying the epidemic is mainly in discordant couples. The other year we are saying the epidemic is mainly in sex workers. So it keeps changing tactics, and it requires us to stay vigilant. To stay vigilant like people at war, changing our tactics and changing our strategies to make sure we don't lose. The moment we slacken, the moment we become complacent, the epidemic reverses. Goes up. Our achievements are reversed. We see the epidemic flailing, the number of people death going up, the number of new infections going up. So we cannot afford to sleep on the wheel on any day until we end this epidemic. And it is possible to make this epidemic history, so that other people are reading about it. The people of the generation of after 2050 should be reading about it, just like we read about smallpox, which none of us has ever seen.
Interesting. Thank you so very much, Daniel. And we're going to take that very direction, especially talking about those stakeholders that are very complacent and also letting us down when it comes to the fight. And that takes me back to Dr. Arthur, especially before we go into how the ministry, whether you're letting us down or you're leading us well, are there any improvements, especially when we're talking about the recent improvements, especially in treatment? Because some of those that PrEP and many others that you mentioned, we're talking about some time back that they were established and introduced some time back. Do we have recent, perhaps in 2 to 3 years, as we commemorate 2024 HIV AIDS Day, that we can embrace and uphold as a country?
Yeah, thank you so much. The moderator, Dr. Dan has ably given us the preamble in terms of some of the probably stakeholders that may have relaxed. I think that's the best word for me to use, a polite way. But like you have mentioned, improvement that we have seen at the Ministry of Health. And I mentioned to you from the start that we have tremendously reduced new infections from initial around 100,000 to currently we are talking about 38,000, but also reduce the number of deaths. We are talking about around 20,000 or less than that, way from around 60,000 infections. Deaths, AIDS-related deaths, just a decade back. Now, on top of that, quite a number of prevention approaches that have been brought on board. One of the prevention approaches that is very, very good, and I encourage people there to go for it, it is what we call the Butebo ring. That ring is a vaginal ring. Yeah, it's a vaginal ring, which is majorly inserted into the canal of the female. It has a drug that is supports in preventing HIV, but this ring is supposed to be used for particular groups of people. When you go to the health workers to the facilities, you will be informed about how this ring is used and which people are meant to be using it. But also on top of that, like I told you, the other PrEP, what we call pre-exposure prophylaxis drugs, still without just diverging so much into its nitty-gritties, the scientific nitty-gritties, this is also part of the prevention approaches that have been brought on board. And in case anybody goes to a health facility, they will be informed of how best this drug can be used. Now, apart from all those, there are quite a number of other improvements. We have talking about prevention of mother-to-child transmission, what we call PMTCT or EMTCT, elimination of mother-to-child transmission. Very tremendous improvements in that area. And what improvements am I talking about? Just a few years back, we were talking about around 6,000 new infections that we are having. Currently, we are talking about 4,700. Now, that is not an improvement that should be taken for granted. It is a very great achievement, even when we want zero infections in children, but at least we are talking about infection reduction in comparison to what it used to be. But still, in that same area, we still have challenges. Challenges to do with women who do not take their drugs religiously, who do not take drugs in a manner that the drugs are supposed to be taken when they are pregnant. Now, this predisposes the children, the unborn babies, to HIV. For example, 40% of infections that happen in the children, they always happen in pregnancy period. Now, it means that when women are pregnant and they don't take drugs the way they are supposed to take them, 40% of the infections will happen. But if they take the drugs religiously, the way they are supposed to be taking them, then we are able to avert those infections. But also during breastfeeding, around 40% of the infections that happen in children happen during breastfeeding period. When women leave drugs, when they don't take drugs the way they are supposed to be taking them, then we end up with having around 40%. So you can see 42% while pregnant, 40% while breastfeeding. So you can see that since we have drugs, honestly speaking, there shouldn't be any, for lack of a better word, any logical reason for a person not to take drugs so as to prevent infection from the mother to the child. So I urge the public, especially our mothers, the women who are living with HIV and who are intending to get pregnant, you need to take drugs religiously so that you don't transmit the infection to the baby.
Okay.
Now, yes, so that is one of the improvements that I can talk about. Even when we are still battling with infections in new infections in children, but you can see that a reduction from 6,000 to around 4,700 is not something that we can take for granted. Amon, maybe if you allow me, I can also expound on the condoms. Now, the condom which is something that most of us know. It is something that we have heard about since nearly the start of fighting against HIV. It is part of the ABC strategy. It is part of the prevention strategy. Now, these condoms are basically effective.
Any improvements on the condoms?
And what? Yes, exactly. The improvement that I want to bring on board is, initially we thought that condom was just going to be supporting us in the fight against HIV. But as we have gone on, we have communicated to the public that a condom can actually be helpful in what we call the triple prevention. Triple prevention in the sense that it would support us in preventing HIV, but it would also support us in preventing STIs, what we call the sexually transmitted infections, and it can also support us in preventing unintended pregnancies. And another development or improvement that I can speak about on the condom is our total market approach strategy and alternative distribution approaches that we have brought on board. All of these are aimed at achieving distribution up to the last mile. You can now go to a lodge, a hotel, and you will be self-supplied with the condoms in what we call the self-retaining supply boxes within those areas. So let us not have challenges in terms of accessing condoms, and let us also not think that the government condoms that are supplied are basically of less quality. All condoms are of the best quality, especially those that are supplied by government and regulated by the National Drug Authority after certification.
Interesting. Thank you so very much, Dr. Arthur. We've been joined by Flavia Chomkama, as the Executive Director of Action Group of Human Rights, coming from that very important civil society. But also we cannot forget the role that advocacy groups have played, especially in the fight against HIV/AIDS. Welcome, Flavia, to this edition again, and I welcome you from that big marathon, Angoya Toro. Okay. Okay.
Yes.
Welcome.
Thank you, Amon, and thank you, dear fellow guests, Dr. Arthur and Dr. Daniel. You are my very own. Thank you for hosting us once again on UBC. I'm Flavia Chomkam. I work for Action Group for Health, Human Rights and HIV. But when I came in, my radio doesn't have anything beyond 90.0, so I could not tune in earlier. So I'm also sorry for coming late. Somehow I overslept. I don't know whether it is Ngwara Yatoro, but here I am. When I came in, Dr. Arthur was talking about the mothers who are getting HIV and the babies being born with HIV. And for me, I'll start from the point of the user and the community. And I would like to say we thank the government for the work they've done, but we also would like to say that we need to do a little more. Because coming from Arthur and encouraging us women, I live with HIV from 1994, and I was able to protect my babies. But I do know that women would love their children to not have HIV at all costs. But the reason that people get HIV and also babies are born with HIV is the big thing that still happens, the stigma and discrimination that continues within our society. And if I look at the results of last year, from Uganda AIDS Commission and UNAIDS, the comprehensive knowledge among women is 56%, and for men it is 54%. And so who should actually do this education and ensure that everyone has information? Because stigma and discrimination is primarily and practically a result of ignorance, limited knowledge, fear of the future, fear of the unknown. And, it's unacceptable that 42 years into the HIV epidemic, we still have stigma, we still have violence. And we continue to see babies born with HIV. And if I recall, 1994, I was part of the PMTCT trial, which started this thing of stopping HIV from parents to the babies. But we are still here as a country. I think we have a lot of things to patch up. One, to ensure that the male engagement strategies is implemented, have deliberate interventions that target men to ensure they support their wives and their sisters and mothers to ensure that they access the ARVs. But I also would like to relate to the recent statistics that last year alone we had 12,000 new infections among adolescents and young women. And I'm watching it even the last meeting we had, the last presentation we had here on Ground Zero. I say that the police crime report says that we have defilement 14,900 or so for last year alone, reported cases. So adolescents and young women getting HIV at that high rate, 80% of HIV among adolescents and young women is not right, but also we are continuing to see normalizing of the defilement. And therefore, if there is defilement, definitely there is live sex. And therefore, it goes without saying that HIV and other sexually transmitted infections will happen, besides the long-term effects of trauma, of fear for going to the health facilities, for fear of being judged. We see maternal death of those who are dying, of the 189 who are dying, 40% are adolescents and young women of the same age. And 24% of those who are dying of unsafe abortion. Look at the defilement, look at the new infection, look at the pregnancy, and who is dying. The same age group. And then when we go to look at the budget for adolescents and young women around safe abortion, around abortion services, it's only 6%. And yet the majority of our young girls are dying because of abortion. So how do we link, as we take stock of HIV in this country, how do we link defilement to HIV, to maternal health, and ensure that our girls are protected? Gender-based violence is on the rise. I think you have seen a lot of femicide, we have seen a lot of defilement. It goes without saying that all these link to the same thing, increasing HIV infection, although at a reducing rate. So we continue to worry as women, and that's why I said we come from the Women at 40 campaign, and this is a group or consortium of women living with HIV, national networks, who have come back to say 20 years, 40 years into the epidemic, we cannot be having our babies who we delivered HIV negative. Our girls, we deliver them negative because we endeavor to get the services, to do the PMTCT. Now they are being infected when they were born negative, and they are delivering HIV positive children. So I think what we need to do is to see how to ensure that we bring back community systems that touch the people, because World AIDS Day this year globally is putting people first, strategies to end AIDS by 2030. I know we are looking at creating, enhancing interventions to end AIDS by 2030. But we must put people first. And I'm saying let's put the people with HIV, these young women and girls, let us ensure that the mental mothers, the mental fathers, the male engagement groups, the apps that are in place, they are being facilitated to look for those who are lost to follow up. Because our young girls are being lost around the transition. Because the young clubs where there is food, there is tea, there is TV, they come at 25 to the adult clinics. So it's difficult to assimilate, because here when you come, you are like a robot. You reach here, they register you. You go there, you pick the medication, go there to the lab. But in the previous clinic, they were being treated as babies. And at that moment, the time of relationships. What are we doing to ensure that SRHR is integrated? And I think the ministry is now going into the integration mode, and they are saying we need to use less money for more services. So if we can integrate HIV into broader SRHR, education, family planning, contraception, abortion care, I don't care whether it is safe abortion or post-abortion, but it's also about abortion care, because we are losing an angle. How do we integrate all these so that this girl is not coming into bits and pieces into the healthcare system? And we are saying community systems strengthening is the way to go. Let's have more peers supporting those who are getting disturbed. Let's see the government investing more into the community structures, because they are the ones which link these people to the health facilities. Okay. And we believe that the new community health strategy is an endeavor to do that. And so we need to see more representation, more participation of the young people, especially the adolescent girls and adolescent boys, young women and men, to ensure that they are part and parcel of the decision-making processes, the programming, and also to monitor what is going on, give information back. Why are these women disappearing? Why are they not bring their babies on delivery? Who is dealing with the gender-based violence? Who at police is receiving the cases of violence, of defilement? Why aren't they going beyond the police to the courts? Why aren't we seeing more people punished for defilement? Why aren't we seeing more people punished or put away for gender-based violence? The femicide that's happening, the murders that are happening in this country. I think as a country we need to start thinking wholesomely and see how one of the issues of violence impact HIV, impact access to services, and therefore impact the reduction in children who are being born with HIV. And also we should think about Uganda AIDS Commission. Daniel will talk about it. The current discussions about HIV response sustainability, because we've been depending on other partners for 20 years. I'm taking ARVs, but it's paid directly by either Global Fund or PEPFAR. So
yes, ever since that
it's
started.
40 years since we started with HIV. 82 to date, it is 42 years.
Yes.
So a person cannot support you forever. How do we generate local income, local revenue? How do you ensure that primary health care is working so that people don't have to first be sick and come for treatment? How do we start thinking about prevention and start planning for future reduction in need for treatment for diseases like HIV and other diseases?
Interesting. Thank you, Flavia. It's always a pleasure having you on UBC Ground Zero platform. Daniel, I come to you before I take a break, especially when we come to promoting health choices. You come from a department that is so much into prevention of HIV, and looking in that very context, what strategies is Uganda AIDS Commission using to encourage people to take control of their health and make informed choices, especially when we talk about prevention methods like condom use, HIV testing, and PrEP? Which are these very most important, but how many people do test? How many people have opted to take these PrEPs? And very many. And yet we have all our hopes in Uganda AIDS Commission.
Thank you. That is a loaded question, but I will try to bring out key issues we emphasize in prevention, emphasize the tools we have, including the new tools, and I will share the statistics where possible. Our foundation as a country for HIV prevention lies in the ABC strategy. Abstinence is number one. It's the safest way to not contract HIV. And abstinence is appropriate for young people or for people who are married, whose spouses are away for some reasons. Many of us, of our spouses, work in a distance. That kind of abstinence that is for married people whose spouses are away goes together with being faithful to one partner. But being faithful to one partner, that means you have already started engaging in HIV, in sexual activity. That comes with testing. So testing is key for those who are planning to start their sexual lives. Testing to know your HIV status. If you're negative, you guard your negative status jealously. We have so many models of HIV testing now. We have tried to bring it closer to the people, including self-testing. So as a national policy now, you can go to a pharmacy, to a drug shop, and buy an HIV test kit. The pharmacy or drug shop will teach you how to use it in the privacy of your home. Or even you can come to the hospital and you say, my husband is shy, he doesn't like coming to hospital. Can you give me an HIV self-test kit? I go and we test in our bedroom. So when we have in stock, we shall give you test kits. You can go back home and test in the privacy of your homes. We notice, as much as we say that the foundation of our HIV prevention strategy in this country is abstinence and being faithful, some is trying to minimize. But for me, as the head of prevention, I'm confident that a significant number of our people are abstaining. A significant number of our people are making an effort to be faithful to their partners. And that contributes significantly to our HIV prevention achievement. And we want to encourage some of the key leaders who are key to strengthening that message, to encourage people on that path to continue. That includes parents. So our HIV prevention strategy emphasizes parenting, that the parent has a primary role. My colleague here, Dr. Arthur, and I think even Flavia, said we have a problem of the highest new HIV infections among young women right now. Adolescent girls and young women between 15 years and 24 years have the highest number of new HIV infections. In Kampala here, if I single out Kampala, 53% of all new HIV infections were among girls in that age group. That is very disproportionate. But you note these are children. So a parent is the beginning of making sure these girls are empowered with accurate information, with accurate life skills, to prepare them for the interaction with a wider society. So the parenting is key. We call upon their parents to do their work. But also the parents need encouragement, including the children need encouragement. So that's where we go to other leaders, including the cultural leaders. We call on the cultural leaders to play a part. They have a part here. There are some of our cultural practices that actually predispose our girls to RHIV infections. Cultural practices like while they are still young. I'm told there are various cultural practices like that practiced by various cultures across the country that predispose, that encourage girls to initiate sexual activity while they're still young. But we call on cultural leaders to provide leadership there to make sure some of the retrogressive cultural practices, we can afford to drop them, and the leaders can make pronouncements, make sure those cultural practices that encourage young girls to initiate sexual activity early, to get married off when they are still young and not able, helpless, with no information, with no life skills, they are dropped. So culture, I go to religious leaders. They have a key part to play in reminding us every day about the importance of abstinence, about being faithful to our partners. They have a key part. So, and all the other leaders, including all the elders in the community, we have a responsibility to teach, especially the young people, the important life skills, to encourage parents to do their parenting role. So the response requires all the leaders, religious leaders, parents, cultural leaders, political leaders, to encourage us on the foundational prevention strategies that I've talked about, if we are going to be functional and deliver prevention to the generations that are coming, to everybody. So we recognize that we have weaknesses as human beings, as the people in the church usually tell us that we are sinners, and for us at the Uganda AIDS Commission, we are not reverends. So we that some people will fail to abstain. They have attained age, they have initiated their sexual lives. We recognize that some, they are not very faithful people, and they are not some. Unfortunately, they are a big proportion of the people we know. We see that among married men, based on the data we have from the countrywide population-based survey, the survey that covered the whole country, we saw that close to 50% of married men indicated that they have ever, in the previous 1 year, sneaked on their wife. We noted that 30% of women indicated that they had sneaked on their husband. Those are significant proportions. So for the sake of those who cannot find being faithful, tolerable, and acceptable, we recommend that they use a condom. A condom, one challenge we notice now is that when the HIV epidemic had started and we had not started treatment, when our brothers and our uncles were wasting away, losing weight, the pain of AIDS was in our faces, was in everybody's faces. I want to remind you that key leaders, I remember leaders like Honorable Dr. Miriam Matembe, moving a banana and a condom, demonstrating and teaching people how to use a condom. I remember religious leaders in churches without fear, without shyness, without reservations, teaching about a condom. We have lost that momentum in promoting condom use. We have lost that momentum. Yet we have a whole young generation, a new generation of young people who, at the time when Dr. Miriam Matembe was very active, Dr. Miriam Matembe, there are so many people like her, leaders who were shameless, who were out to save the population, moved around with condoms and bananas, and whenever they stopped to address masses, they pulled the banana and demonstrated condom use. We have a whole generation who were babies at that time, have never had a chance of anybody demonstrating to them about the condom, teaching them about the condom. So even condom use, skill, self-efficacy has gone down. We have a whole generation who have initiated their sexual life. They don't know how to use a condom. Who took this message to the community? It is our leaders. It were church leaders in church telling us, don't be negligent. If you're still struggling with the behavior, use a condom. It was political leaders It was our community leaders. We see that kind of leadership has gone down.
Okay.
We call on the leaders to go ahead and resume leadership, because 2030 is not far. It is just 6 years. If we don't wake up and mobilize as actively as we mobilized in the 90s, we may default on our commitment. But we notice in the response that even some people who fail at abstaining, those who fail on being faithful to their one HIV negative partner, those some don't want to use a condom. We even have tools we have put in place for those who cannot use a condom.
Okay.
Now, our number one HIV prevention tool, I think the one we are counting on most to give us the best reward, is effective treatment for our brothers and sisters who are already living with HIV. We have discovered that when people living with HIV test for HIV in time, I discover the HIV positive in time, start treatment on time, and are supported to take the treatment as the doctor prescribed, they reach a time, it doesn't take long, they become and undetectable, and they don't transmit HIV. So that's what. But as my colleague Dr. Arthur will show you, he will tell you that we start people on treatment, some disappear, some take as the doctor prescribed, and that is because of various challenges in the society. I hope we shall have time to discuss those challenges and call upon our people to make sure we support everybody, every brother, every sister in the household, in the community who has HIV, to make sure they take their medication well. It is good for them because they will stay healthy and take care of their children and don't leave us with orphans, but they will not transmit HIV in the community.
Okay. That will come after this very break. Dear listener, we are talking about corrective action and how can we sustain and accelerate HIV progress. This is UBC Ground Zero on 5 radio stations covering entire Uganda, also streaming live on YouTube. We just enter UBC Ground Zero and you'll be part of the conversation. I do have a privilege and honor to have Dr. Daniel Byamukama, who is coming from a Uganda AIDS Commission and is the head of HIV prevention. I do have Flavia Chomkama, is the executive director of AGA, and also Dr. Arthur Ahimsiwe is the national tail for adult HIV care and treatment, coming from the Ministry of Health. Ampaide Amonoptega is my name. I'm taking a very short break, and when I return, I'll be reading your messages and picking your calls, what you think needs to be done to make sure that by 2030 we are able to end this HIV, but also what do you think has been missing, what is the missing link to make sure that we all move together as Ugandans as we prevent the HIV AIDS in this country, but also reduce infections as the number is increasing, as we have seen and heard from the guests that we have in the studios of UBC. 6506 511-426 is the number you can call. It is 0776 511-426. Keep your messages coming through, and I'll be picking your calls when I return. This is UBC Ground Zero. I'm coming back in just a bit. Don't go away.
This is Ground Zero Season 2. Stay tuned. We shall be right back. It's hot.
We lost it. We didn't know exactly what the problem was on the ground. There is no pretending about the effect of this thing. There's no pretending about it. Nobody should. It's a problem.
It's balanced.
This is not the stage at which you start planning to tax a commodity like coffee, especially from down there.
It's intellectually engaging.
The Constitution provides that the land must be registered under the customer tenure system, which is one of those that's recognized by the Constitution.
Ground Zero Season 2, live and syndicated on your public and national broadcaster, UBC, inspiring Uganda.
The Education Forum program. Education Forum, a platform for trends and developments in the education sector. We are your reference and reliable source of information. The Education Forum, right here on UBC Radio. Inspiring
Your
Uganda.
Voice Talk Show.
The biggest concern now is the quality of education. That is what is bothering us so much.
Addressing Uganda's governance issues.
Incidentally, there is now a new trend. There is more land wrangles in families than Vivanja land title holders.
Monday to Friday at 7 p.m.
With this integration of East African community, we must work hard so that we benefit.
Your Voice Talk Show, only on UBC Radio, inspiring Uganda.
Music on UBC Radio. The hits just keep on coming.
If you want to touch my body,
more hits on UBC Radio. Your music. On UBC Radio, we play music of your choice, day in, day out. We got more hits for you, so stay tuned.
Uganda's #1 hits.
Ling-a-ling-a-ling-a-ling-a, baby. Ling-a-ling-a, everything go be well.
Keeping it home-based. You are listening to UBC Radio.
Welcome back. Ground Zero Season 2 continues. Welcome back. Ground Zero Season 2 continues.
Interesting. Welcome back from that very short break. This is UBC Ground Zero, and we are live on 5 radio stations covering entire Uganda. This is UBC Radio on Kampala, and can get us on 98.0 FM, Alwa 97.4 FM, Lila 99.4 FM, and we are on live on Butebo Radio in Eastern Uganda. That is in Mbare 96.9 FM. So 98.4 FM, and we're also live and clear on Voice of Wondobojo, the Western Nile Radio in Arua, and Magic 100 FM in Kampala. Streaming live on YouTube, just put UBC Ground Zero and you'll be part of the conversation. 0776 511 426. What do we need to do to make sure that we end HIV or AIDS in this country? What do you see as a missing link, especially when it comes to prevention, especially when it comes to young ones and the youth, but also what do we need to do, especially when it comes to treatment? That is the number you can call and keep your messages coming through. I'll be reading one by one. UBC Radio, Ground Zero. Hello. Okay, call us again on 0776 511 426. You're live on radio? Ground Zero? Ground Zero.
How are you, Mr. Amon?
Fine, thank you. Your name and where you're calling us from?
I'm calling Guma. I'm calling from Matuga.
You're calling from?
Matuga.
All right.
Before I put on what needs to be done, I have some 3 inquiries here. I would like you people to help me.
Okay.
Why is it that much effort is always put at this point? Number 2, this one goes to the doctor. My uncle died of AIDS. But up to now, the wife is negative. Even the wife got married. In their family, they are negative, but my uncle died of AIDS. How possible is that? I would like to understand that.
Okay.
Now, number 3. Is AIDS not really a business for Muzungu? Because during COVID-19, they were questioning why blacks are not dying people like those in other continents.
Okay.
Because they are here where there's war, there's business. Maybe perhaps where there's sickness, there's also money because we are buying things, medicines, Now what needs to be done? Parents are falling off track. They no longer want to sit with their kids, leaving children with mates. Before the religion, or maybe the media, parents, they are forgetting their role. But I appreciate you so much. This show is actually educating us a lot.
Okay.
I thank you so much.
You're most welcome, sir. 0776-511-426 is the number you can call and share your perspective on the topic, especially HIV and AIDS. You're live on radio?
Yes, good morning, UBC.
A very good morning to you. Your name and where you're calling us from?
You're talking to Richard from Kansanga.
Okay.
First of all, I have something to ask.
Okay.
I just want to know whether, condom, they say it is a safe one to be used. I see some ladies, they're complaining like, I don't know the oily, which is on condom, whether it is safe, because ladies normally complain that it is burning them. So the second thing is, it's like a challenge, which is going to stop us to maintain the target in 2030. People are now using their richness to infect young ones. You see, a rich person want to stay with the young girls, and even women who are infected, they want to sleep with the young men who are not infected.
Okay.
One of my colleagues lost a job because his boss wants him to sleep with her.
Okay.
He refused, and then they chased him away from the work.
Thank you.
Those are the challenges which I'm seeing.
Okay.
Yeah.
Thank you so much. Okay, some messages coming in, but also keep your messages and calls on 776-511-426. Komakech says, we no longer have HIV activists and influencers. Doctor was talking about Honorable Matembe. If they are no longer on the forefront, why not Uganda AIDS Commission collaborate with other key figures in our communities, and then we keep the fire burning? We have indeed relaxed. UBC, ground zero. Ground zero.
Hello.
You're like,
Yeah, this is me, Dennis, from Awinga Primary School.
From
Awinga Primary School in Yumbe.
Okay, you're live and clear, sir.
I thank you for the program.
Most welcome, sir.
It's real painful that when AIDS is coming to our homes, we are real unhappy because we leave children unhelped. So it could be we as the parents, we have to take initiative of protecting ourselves, even the children, which are so educative to us.
Okay.
In most areas, now you see, I have heard somebody here saying that it is sort of business. For me, it is not sort of business, because AIDS was a terrible disease, but only that we are not careful to protect ourselves.
Okay.
This is what I can comment about.
Thank you so very much. Okay. Some serious concerns there. Okay. Someone says also, let me finish with the calls. Live on radio.
Hello.
You're live on radios.
Yes, hello.
You're live and clear. Your name and where you're calling us from?
Yes, how are you doing?
Good.
I'm calling Popra from Uganda.
From? Please increase on the volume of your phone. We're not able to hear you. Ground zero.
Hello.
You're live and clear.
Yeah, talking with Emma.
From where?
From Arua.
Okay.
But no, even if, for example, I play with, I'm sleeping with a girl with HIV right now. I get it the HIV even right now. Yeah, I don't talk how long to that HIV to disturbing me.
Okay.
Yeah, I go talk 1 month over 1 week.
Okay.
Okay.
Thank you so much. Messages still coming in. Someone says that Dr. Daniel says that the ministry has relaxed and so the people of Uganda, but also I think that the commission, Uganda AIDS Commission, also has relaxed. That it needs to be visible. Gone are the days when they were at the forefront educating the people, but now you rarely hear from them, and this reluctancy has made the people of Uganda, especially the young ones, not to know about anything about prevention or the dangers of HIV. So they need to really, as we celebrate this year, commemorate this year, they need to up. Okay, that message, I think, lost that message. You can finish your message, but was saying that you see, the UAC needs to perhaps come forward again. Someone says, do how cure HIV AIDS? I have seen so many people go to some doctors in our communities taking herbs and saying that when you take some herbs and eat well, you are able to cure from AIDS. Ground Zero.
Hello, good morning.
Good morning to you. Your name and where are you calling us from?
Talking from Odunga Manuel, I'm calling from Sitende.
Okay, your concern, sir?
For me, I have just a question for doctors there.
I had the relationship with someone with HIV on 2nd of September this year. Then after like 5 days, I realized the ARV medicine on her bag. When I asked her, she denied. But some people know that she's taking. When I took her for testing, they got her negative. But she's on the medicine.
Okay.
I tried to check her, she's negative. Now I was like, is it possible these drugs can hide the medicine?
Okay.
And if they can hide it, is it possible that I can also contract it after her being the negative after testing?
Okay.
Yeah.
The doctors are going to answer you on that.
Thank you.
Allow me end calls for now and the messages because time is not really on my side. I have to go back to the studios for my guests in the studios to be able to address those concerns. I'll start with Fravia and then Dr. Ahim Suwe and also Dr. Daniel to answer the callers. But you'd realize that we have very few minutes to end our conversation. I would request that you use a very, very limited time, especially when it comes to your turn and addressing, because we still have so many topics to look at. Fravia.
Thank you very much, Amon, and good morning again, listeners who might be new to the show and for staying around. I just want to respond to the last one to say that the medication you saw could be indeed, they look like ARVs, but we also have what we call pre-exposure prophylaxis. There is also a kind of ARVs that people take when they are HIV negative to ensure that they don't acquire HIV from anyone. So it could be that, but also I don't think that if she was positive, the medication can make her negative, because I've been on ARVs I've been HIV positive since 1994. I've been on ARVs for the last 21 years, but there is no test that I've ever gone and ever tested negative. So if it was an authentic health facility, definitely she's negative or she's taking pre-exposure prophylaxis. But if it is just any other clinic, go to a government or public health facility, get the right, get tested again and be sure that the result is right. Then the teacher from Yumbe Primary School, yes, it is about protection. How do we protect our young women and girls, our adolescent boys and men from getting abused, from getting HIV infection? I think protection is fundamental. And for me, the mainstay for HIV prevention is this in this country is social support and protection. Because when people don't have food, don't have education, don't have good Medicare, don't have the belonging or even the affection that they require, don't have the counseling and the psychosocial support they require, many times they drop back. That's why we are seeing a number of those who have already initiated on ARVs are actually running away, and for fear of the stigma and fear of what will people think. And we can only do away with that by giving information around the relationships. The infections are actually, the new infections are seen, 46% of new infections are from adolescent, from young boys and men. So it's not really, but also we see that women and girls are also having HIV. So the infection doesn't really come from those who are older or younger. It is that who is HIV positive, whatever age group that will infect the other. And also that because people have become lazy, we don't want to work. You hear on radio, on TV, people are saying, I want a woman who is driving, who has their own home, where I can go and give love. Another one says, I want a man who already has a home, who is driving. What do you expect? You need to work to earn these things. You don't just go because somebody has already made it. And that's where we are landing into problems. So we need to learn to be content with our life and move our lives step by step, not wanting what a person who has worked for 40 years has, and yet you are just coming into the workplace. So it's important that we start thinking about how to live and ensure that we live well. And then for the first one who said that HIV is a business, no, it's not a business. We are here, we live with HIV. We know the pains of going with HIV. We know how to deliver children who are with HIV and what pains it takes to even lose your child you have born with HIV and they die at 28. I, for one, I've lost my son at 28 who was born with HIV. So don't just joke around. HIV is here. It is for real. It kills. If you take medication well, you live longer. But if you joke around with the medication and you just take as you wish, then you know the consequences of taking ARVs and taking them not well. But then also for the people who are getting lost to care, it is especially for the younger ones, it's relationships, it is distances. There's those things that happen, especially for the young ones, stigma and discrimination. They fear to be seen, they fear what will people say. And we have seen some places where people are actually deliberately abandoning children not to go to school because they're HIV positive. They are not giving them the care they require. So, you know, we need to do this collectively in solidarity to ensure that those who are positive, like me, continue to live positively without infecting any other person, because the way I've taken my medication, my viral load is undetectable, so I'm not able to transmit to any other person. If I ever had live sex with anyone, I would not. But they are viral suppressed. I know that is a lot of science, but I have the doctors here who know Uganda, who know Chiga, who know Lugwa, can always translate and let you know that it's possible to not transmit when you're HIV positive if you are taking your medication very well. Thank you.
Interesting, Dr. Imsu, and then I'll come to you, Daniel.
Exciting to hear the interest that people still have in HIV messages, because I was I think seeing you getting a little bit of challenges with the traffic of callers. So it is basically encouraging, and it shows that people are still willing to listen to HIV related message and probably put strategies in order to avert the infection. And with that zeal, there is no doubt that we are moving towards ending AIDS by 2030. Quite a number of callers. There is one caller who talked about having a wife who is HIV negative, and he fears that how possible can that be, or isn't he going to get infected again? Without raising your anxiety, but the direct answer to give you in order to up your game is there is a possibility of contracting the disease if you don't seek healthcare advice. But if you go and seek healthcare advice, I can guarantee you that you will be supported and there is a very big possibility that the advice they will give you, the support they will give you, will help you and prevent you from contracting the disease. Now, what you mentioned is what we call discordant couples. Discordant couples having one partner with the disease and then the other partner without the disease. It is very possible. Now, the other partner who doesn't have the disease must take precaution measures given by the healthcare workers in order to remain negative. If you do not take precautions and take it as business as usual, I can guarantee you that there is a possibility of contracting the disease. So in a nutshell, what I'm telling you, the caller, I have forgotten the name, the caller who asked this question, kindly go to the health facility which is near you, either in your parish, either in your sub-county or at the district level, whichever health facility that is near you, just go there and you will get the best advice possible. If I were you, actually, now I would move with my radio just now. I go to the health facility and get the advice that I can get from the healthcare workers there. I have not done that question, but I don't want to give you false hope. And since we are on a national radio, giving a hope to you may give again also false hope to other people who may take. Then you stand very high chances of contracting the disease. Now, the other person said that isn't globally we have around 39.9 million people that are living with HIV, and Africa basically takes nearly the largest share of the people that are living with HIV. But also to say that we have people living with HIV in Europe, we have people living with HIV in Asia, we have people living with HIV in South America. Basically, we have people living with HIV nearly in the whole world. So it is not a Muzungu kind of business. The Muzungu has supported us in terms of giving us support with drugs, with logistics, with all necessary things that we would need in order to fight the pandemic. So even when the country has a very big proportion and a very big percentage of support that it gives, but it also happens that the donors, the supporters, what you have called the Muzungu, they have also given us support. And this support has come through what we call PEPFAR, it has come through what we call Global Fund, it has come through what we call quite a number of different institutions that have really supported us. So the clear answer is it is not really a business of the Muzungu like you.
Is affected.
Yes, because the Muzungu is affected. It can't be his business when he's affected.
It's also the same virus.
Exactly. And these are the misconceptions or the myths that we need to debunk in whichever area. Yes. So the person who has asked about it, I wish to think that he is now an ambassador. He can go and spread the same message to other people. Herbs curing HIV, honestly speaking, it is a big no. There is no way, there is no herb that we know of that can cure HIV. So I think I can stop from there for now. In case, moderator, there is any kind of clarification that you would wish us to bring to the listeners, I think we can do it, because I believe that we are here because of the listeners. So the more time you give to the listeners, I think the better.
Interesting. Okay, Dr. Nile, now you come in. Someone heard that you have also relaxed because you no longer really come forward to have all these engagements, especially community engagement and also teaching the people on prevention measures. But also some messages coming in also show that there are people who are on self-medication. Someone says, this medicine is the one that works well for me. What would be your comment on that? But also we have failed when it comes to stigma. Gone are the days when people would come up and then give testimonies on the same, but someone who has HIV, the best way to run or to hide is in their houses and keep quiet forever. And it is the same that has limited many people to go for testing, fear to be stigmatized, especially in communities.
Thank you, moderator, and thank you, our listeners, for those intriguing questions. There are several other questions that my colleagues have talked about, tried to respond to, but I also feel I should weigh in as somebody from the Uganda AIDS Commission. The first question that caught my interest is from the first caller. He said, why are we putting so much effort on HIV? And the same person who asked that isn't AIDS a Mzungu business. So from my thinking, he's totally a very suspicious person, thinking we are here trying to advance a Mzungu business. But Amon, you'll agree with me that this must be a young person who never saw what most of us saw in the 90s and the 80s. So I want to assure the caller and fellow young people that AIDS is real. AIDS is real, and before we had antiretroviral drugs, treatment for HIV, our brothers and relatives who contracted HIV went through a painful process until their death. The sickness was painful. They lost weight. Somebody with the 120 kilograms would lose weight and die when they are 45 kilograms. So you can understand. And if he's your brother, every time you saw him, you would cry. You would feel like crying. We still have those memories, and we would not want to go back. We must put our energies together to make sure we don't go back to seeing what we're seeing. We go back because, number one, the treatment of HIV is very expensive. Right now, we have 1,500,000 people living with HIV in Uganda. We spend 800,000 per person to keep them on treatment per year. If you get 800,000 per person, you multiply 1.5 million per people, you get a figure. If you have a calculator, the listener, try to do it. You figure that you cannot put in English or your local vernacular. That is the amount of money we spend. So we would not want to see that number increase, because eventually we shall reach a time where almost all the money the government has goes to treating people, keeping our brothers and sisters with HIV alive. So we would want to emphasize prevention. Go and prevent. Use the prevention tools that we have shared with you today. We have talked about abstinence. We've talked about being faithful to a partner. We've talked about condoms. Condoms are safe. Somebody asked about condoms. And unfortunately, I see that people are always finding so many excuses, creating so many myths about a condom to find a reason to not go with a condom. If they are asking for scientific reasons for their safety, but many people are asking questions that negate the importance of a condom purely because they want a psychological justification why they should go without a condom. I let you go without a condom, my friends. The condoms are safe. There is a whole department, a government department in the Ministry of Health called the National Drug Authority. It has a laboratory, a state science laboratory. It's a laboratory of the same quality as the laboratory in America or Singapore that tests every condom that comes in the country. Every batch of condom that comes here is tested by our National Drug Authority to verify that it is fit for our Ugandans. The National Drug Authority is manned by brothers and sisters. Ugandans, they are not Mzungus. They are taking care of us. So I want you to have faith that when they have tested, they are looking out for us. Some of the businessmen from the countries that manufacture condoms may be lazy, but I tell you, our brothers and sisters, the National Drug Authority do everything possible to test every condom. The ones that they find unlacking, they send them back to the supplier. The ones that are sent down for your consumption are secure condoms. Somebody is looking out for you. Don't find an excuse to blame the condom or to not use the condom. Don't accept any myth. We see people saying because Rough Rider costs more money than the pink condom, so it means Rough Rider is more effective than the pink condom. But it's not true. All of them are tested in the same laboratory, and all of them are passed by the same person. Only that some people like expensive things, and we have to meet that market. Some people cannot afford a condom, and we need to take care of those. But all of them, the condoms are of good quality. So Another person asked about, of course, the other prevention tools I have not talked about. I have not talked about the importance of circumcision. Circumcision is not bulletproof. The listener there, I want to warn you, circumcision is not bulletproof. But we realize that the other alternative is that people go without any protection. So circumcision offers you partial protection of up to 60%. You need to be armed with that 60%, because very often, if you are going to make a mistake of engaging in high-risk sex with somebody who's not your wife, somebody with whose HIV status you don't know, very often people don't use protection. So you better be armed and go with that 60% wherever you go as a baseline, as a starting point.
You have already secured 60.
You have already secured 60. You have already secured 60.
You are safe.
And now we see, when we do surveys across the population, we see that 60 is saving so many people. It is working so effectively. Among men, we see significantly that men who were previously married, the men who divorced or separated, they take position number 2 in contracting new HIV infections, after the adolescent girls and young women I talked about. But when we look further at these men who are the divorced, separated men, we see that around 95% of those who contract HIV among these men are the uncircumcised men. When we see among the young men, the youth, the unmarried boys and men who have contracted HIV, we see that the uncircumcised boy contributed 7.5% of all new HIV infections. The circumcised boy contributed only 0.5% of all infections. So 30% is very helpful. I encourage every man who is not circumcised to go and circumcise. We have other tools for prevention. For those who cannot abstain, be faithful, or use a condom, we have what we call pre-exposure prophylaxis. If you live a life where you cannot abstain, you cannot be faithful to one partner, you use a condom, you will come, we shall give you medicine within the hospital. We have various, even an injection, which you take every 2 months. If you live a risky life, that injection or that pill will save you, will help you not contract HIV. Number 2, we have post-exposure. We have had the discussion about the problem of young women. But between me and you, the listener, we know that a significant proportion of our young women contract HIV because somebody has tricked them. Somebody has enticed them into the sex they were not prepared for. They are young women. Their bodies may look like they are mature. They have breasts and nyash, as they call it. But spiritually and intellectually, they are young. They have not yet developed life skills. Somebody can easily trick them and seduce them and mislead them, and they end up engaging in sexual activity they were not prepared for.
Okay.
So we would want people who end up in engaging in sexual activity they didn't know, with a partner whose HIV status they didn't know, or people whose condoms have burst or have slipped off. You can still come to hospital after you've made such a mistake. Within 3 days, we shall give you medicine. We call it post-exposure prophylaxis. It will save you from contracting HIV.
Interesting.
By talking about the person whose uncle died of AIDS and the wife is still negative. That phenomena, we call it discordance. It is real. So our estimation shows that for every couple where couples, married and married woman, for every 2 couples where both wife and husband have HIV, there is a couple where only either the man or the woman has HIV. This is called discordance, and it's because the chance for HIV transmission has not happened. So what happened in your uncle's life is true, but if you are discordant, you go for an HIV test and your sexual pattern is negative and you're positive, you don't take it that you're bulletproof. It's a matter of time. If you continue to engage in high-risk sex, in unprotected sex, or if your partner does not start on treatment and attain that status that Flavia talked about called undetectable, then she may transmit HIV to you. So we encourage partners in discordant relationships. They are real, but they minimize the chance that they will transmit if they use protection, or if the partner who is positive starts on ARV immediately, is supported to adhere and attain an undetectable state, there will never be transmission of HIV.
Thank you. I do have a really lot to talk about, but time is not on my side. And Dr. Arthur said we should really prioritize the concerns from the listeners, and that gives me another chance to put one concerns to you all. But we had a concern from a listener who asked, can I ask the one from the ministry about the injection? How far is the injection, and is it for prevention or for those that are already on treatment, and how can we access it, we who are in the villages?
Okay, great. Thank you so much, Amon, again. Now, I know many people talk about injection. Now, injection is part of the PrEP, what we call pre-exposure prophylaxis program. Now, this PrEP program has expanded currently. We initially had only 6 health facilities in 2017 that had that PrEP, pre-exposure prophylaxis program. To currently, I think it is in around 635 health facilities across more than 60 districts. I think to be exact, around 65 districts. So community engagement has been strengthened with over around 75 community dropout centers. That is what we call drop-in centers that actively provide these PrEP services. But also to mention that more than 700,000 clients have been reached with the PrEP provision. Now, the PrEP provision, that is the... I know your interest is on the injection, yes, but it's also good for me to give you this information. The PrEP prevention. Now, on that same PrEP, there are new interventions that have come on board. What we call event-driven PrEP. There is also what we call PrEP vaginal. That is the ring that I talked about. And then lastly is the injection, what we call the injectable PrEP, the cabotegravir, the injectable PrEP, which is yet to be also introduced. All these are done in order to meet the diverse needs of the population that are at risk. Now, the advancements that I have mentioned highlight Uganda's dedication to the implementation of the, what we call the cutting edge solutions in the fight against HIV. Now, to focus more on what you asked about and what I think the listeners want to understand. Now, the injectable PrEP is an injection that basically has ARV drugs within it. Now, that injection is given to a person in order to protect him or her from contracting HIV. Currently, this drug, I can say that it is still under scrutiny, investigations, because even when it was approved in other countries, it is a drug that we cannot start using for ARV provision, for mass provision of people, without first doing investigations on it. So it is still being tested. It is a drug that has been proven to work in other areas, in other countries, probably maybe in Europe and America and that kind of thing. But for us here in Uganda, we thought that there is a need for us to prove beyond doubt that it is a drug that can be contextualized and can be used for our population. So we are using it here in Uganda, but under very controlled situations as for now. That is the research, the research grounds, and at an appropriate time, when it is available for massive use as a PrEP, we shall be able to inform the people and even take it in the health facilities where the people can find it. The healthcare workers will tell you the categories of people that can use it as of now. Yes, so when it comes on board, be sure we shall be able to tell you. But as of now, we are not yet using it as an ARV drug for mass people, though people seem to like it, people seem to want it, but there is need for us to know that it will come at the right time, and we shall be able to inform people that now we can use it massively. Wherever they are using it now in Uganda, like I have told you, we are using it in a highly controlled environment. When I talk about highly controlled environment, I mean the research settings.
You're right.
Yes.
But Sava says that I don't really understand when it comes to fight against HIV. Why don't we have Chua by now? We are talking about 40 years plus, and we have seen other diseases have their medicine. Cancer, if early diagnosed, you can be treated and healed completely. We see the COVID-19 was here just a few years, but why has it taken HIV all these years and we don't have a Chua for it yet? I will go with the first caller who said that someone somewhere must be benefiting in AIDS.
Yes, Amon. I am absolutely sure that you even when you say that you will go with the first caller, I'm absolutely sure that from the information we gave, I think we tried to debunk that information that maybe, the Muzungu and that kind of thing. So what I want to say, HIV is a very, very dynamic virus. It is a very dynamic and interesting in a negative way, that for it, why it is difficult for us to get, why it has become difficult for us to get the Chua as scientists, it is hinged majorly on the fact that when this virus enters the body, and I repeat, when the virus enters the body, it looks for ways and means of mimicking the body cells, entering into the body cells, and it starts mimicking the DNA of the person. So even when it is a virus, but it starts mimicking, that's why it's not like there is no drug that can kill the virus. No, the drugs that can kill the virus are there, even when you put it like outside the human being. But when it enters into the human being, it starts, it integrates, I think that's the scientific word, maybe, for lack of a better word. It integrates itself into the human DNA. So the human cells and the human cells cannot easily be differentiated from this virus. So the DNA of the human and the virus, they incorporate, integrate into each other, and you can't easily differentiate them. So when you give a drug that would kill the virus, it will instead also target the body cells and kill the body cells.
Thank you.
So it has become difficult, but efforts are on to identify the virus. There are some studies, clinical studies that have been going on in order to identify the virus for HIV.
Thank you so very much, Dr. Arthur. Some lady, Samantha, is listening to us and I have heard from my fellow lady in the studios there. Thank you for representing us. But I have a concern, and it is a concern to all the women in my community. We are forced into female genital mutilation. We have started going to the caves to be cut, and they are using the same equipments. Isn't this a risk for us to be infected? What should we do?
Pardon on that?
Is that I think on those that she says that is Samantha, that in their community they are forced into FGM, and that perhaps she thinks that puts them at the risk of being infected because they are using the same equipments as the women. How can they be helped?
Thank you very much, Samantha, for that concern, and I think that is brave of you to even make a call on the radio right now. I do understand that FGM in this country has been outlawed, and that's why they are taking you to the caves. In that case, if they are using the same sharp instruments to cut the women's clitoris in the name of circumcising them and, for the future sexual relations and enhancement of relationships for the husbands. That is wrong and will definitely transmit, because we know that the highest concentration of HIV is in blood, and so if a person has got HIV, they use the same knife used on another girl, means that some of them are going to get HIV. I also would like not to say much, but I know that the government person here should be able to clarify a little more. But if you could be strong enough, you can see how to run away or even refuse. I've seen people who have run away, gone to the police, reported, and being protected by government from this inhuman act against a woman's body. Okay. And so if you can, try to reach closely before you go to the cave. I know the cave is very far in the hills. You may not be able to leave. Or if you have a phone like you have done now, use it to alert someone who can tell the police. But I know that your family members may not. You need to have somebody you trust and relate with, who can help you. Thank you.
Time is not on my side. I would request you to give your parting shots, especially on the national and international themes, but also call the people of Uganda to join you tomorrow as you commemorate the World AIDS Day.
Yeah, thank you so much, Amon, and thank you so much, listeners. From the time we started up to now, the theme for tomorrow's World AIDS Day goes that accelerating the interventions to end AIDS by 2030, and we can't end AIDS by 2030 without without various stakeholders. And among the various stakeholders are people of Uganda, people who are living with HIV, and the entire fraternity of the people in the Republic of Uganda. So I call upon all the people to join us tomorrow so that we commemorate the World AIDS Day. But also, Amon, it would be unfair for me to end without calling upon the people who are living with HIV to continue taking drugs in a manner that is religious. They shouldn't leave the drugs. Time is now when we have the drugs available with us. It would be very shameful if we say that retention of people living with HIV on drugs is bad or it continues to drop. So this is an urge and very urgent call for all people who are living with HIV to continue taking the drugs from the health facilities so that we have better quality lives.
Interesting. Thank you, Dr. Arthur. Your parting shots, Flavia?
Thank you very much, Amon, and thank you, listeners. And those who took time to send questions to us, we thank you and respect your ability to wait on us. I am saying that for all of us in this country need to be more vigilant, because HIV is still here. We had 38,000 new infections last year, and like we say, we have not yet attained epidemic control. We are having less people dying compared to those new infections. What can you and I do to ensure that we prevent HIV? And we know that HIV is preventable by getting your test and remaining negative. We also know that AIDS is manageable because now we have the treatment for HIV. We have the treatment that can prolong our lives. We can also have a cure for TB. We have a cure for malaria. We have a cure for all those other diseases that are opportunistic, that hurt us because of our reduced immunity. But finally, I want to call upon people living with HIV, especially women living with HIV like me. Please take your medications very well. Take care of your children very well. We need to save the babies in our wombs, because you know how it is painful to take care of a sickly child. Please go get your medication. It's not about your boyfriend or your husband. Get the medication, take it. Tell him if he's getting violent, let him be, leave him, but make sure that that baby is protected. But also you, don't get off your medication because you're in a relationship. Find a way to go to the health facility and get the support you need to disclose to your partner or your loved ones. And the rest of you who are not HIV positive, please look at us, support us, because we both work hand in hand to ensure we end AIDS by 2030. I thank you.
We also want to thank you in a special way for always making time to come through to UBC and inspire the people of Uganda. Flavia Chomkama is coming from AGA and is the executive director. We also had Dr. Arthur Ahimsiwe is the national team leader for adult HIV care and treatment, is coming from the Ministry of Health. And we also had the privilege to have Dr. Daniel Byamukama, is the head HIV prevention, coming from Uganda AIDS Commission. Thank you, gentlemen and the lady. We've been talking about corrective action to sustain and accelerate HIV progress in this country. And we're live on 5 radio stations covering entire Uganda: UBC Radio in Kampala, UBC Western Nile in Arua, UBC Butebo in Eastern Uganda, Magic 100 FM in Kampala, and also Voice of Vunduvujo. And we're streaming live this program on YouTube. Just go to our pages, UBC Ground Zero, and you'll be able to follow this conversation anytime you want. And the repeat of this program is always on Sunday from 3 p.m. to 5 p.m. on UBC Radio 98.0 FM, and also on Voice of Vunduvujo on Monday same time. You can always create time and listen to it again. Thank you for our dear listener for being part of us from the time we started this conversation until now that we have to end. And also want to thank those who called in and sent the messages in this program. Thank you for your time. And next time, Saturday, same stations, same program, and also looking at a very different topic. We make sure that we move together as the people of Uganda. For God and my country, I'm Peter Amon Ortega. Allow me now to sign out.
That was Ground Zero Season 2, a production of Uganda Broadcasting Corporation, UBC, inspiring Uganda.
That's it. We didn't know exactly what the problem was on the ground. There is no pretending about the effect of this thing. There's no pretending about that. Nobody should. It's a problem.
It's balanced.
This is not the stage at which you start planning to tax a commodity like coffee, especially from down there.
It's intellectually engaging.
The Constitution provides that the land must be registered under the customer tenure system, which
UBC, inspiring Uganda.
Don't miss UBC Radio Ground Zero every Saturday from 10 a.m. to 12 p.m. We host credible and relevant guests to discuss pertinent issues of national importance aimed at addressing people's concerns.
As a country, if we don't fight this vice of corruption seriously and with honest opinion without any bias, things will not be good for us.
UBC Radio Ground Zero, right here on UBC Radio.
UBC, ensure that the information you give out is factual but also objective, balanced, and complies with the legal and policy requirements for the media.
Ground Zero program is always live, loud and clear, every Saturday from 10 a.m. to 12 p.m. on UBC Radio, Butebo FM, West Nile FM, and Magic 100 FM, and live stream on YouTube. You can also listen to the repeated broadcast of UBC Ground Zero every Sunday from 3 p.m. to 5 p.m. UBC Radio, inspiring Uganda.
This is UBC Radio.
At UBC Radio, we bring you Uganda's latest news and information.
Focus on Parliament.
What we need to do, the Prime Minister must give us the position before we finalize the budgeting process.
Enjoy sports. The environment. Politics.
The mission we have is socio-economic transformation.
Health.